Coming up today,
oh my gosh, like
and her
genetics. This research saved my life.
Coming up today, her mom, her uncle, and her cousins all had the same cancer, and avoiding the same fate required a drastic surgery. Good morning, I'm Jessica Lovell, and welcome to the Morning Medical Update. Priscilla Brittine lives without a stomach. She had it removed, not to treat cancer, but to prevent it. Before we learn why, let's get, though, to our morning rounds today. Heat alerts are in effect for 45 million Americans across a dozen states. Dr. Adrienne Malik is here to help explain those health concerns related to extended heat exposure. She is an emergency medicine physician here at the University of Kansas Health System. Dr. Malik, good morning. How are you?
Good morning, Jessica. I'm great.
Good. Hopefully staying cool. I know we're all fighting to do the same. When we talk about heat and our health, there's what we talk about as heat exhaustion, but even more serious, we hear of heat stroke. So explain the difference.
Yeah, so these are basically two things that we are concerned about with heat exposure that sort of exist on a spectrum, with heat exhaustion sort of being the lower end of the spectrum and heat stroke being what happens when you have basically end-stage heat exhaustion. So in heat exhaustion, we see people who have been exposed to heat, whether it's through activity outside when it's quite warm, whether it's being left in a hot car or in a house or some area where they don't have access to things to help them stay cool, and they start to develop symptoms that are indicative that their body is having a hard time dealing with the temperature. These symptoms are things like nausea, headaches, dizziness, fatigue, muscle cramps. But these patients and these individuals that you come in contact with will still have normal mental status or still be acting like their normal selves. The difference when we categorize this as heat stroke as opposed to heat exhaustion is that these patients now have altered mental status or are now no longer acting like their normal selves in the setting of being exposed to a high degree of heat.
So I guess that's how we would spot the difference. How would we know when to call 911 and call for help?
So it's always best to err on the side of caution. If you have a family member or come in contact with somebody out in the wild when it's this hot outside who is complaining of any of the symptoms that we mentioned for heat exhaustion, or is altered or down on the ground and is hot to the touch, you should just call an ambulance, because the other thing that we use to differentiate these two heat etiologies is temperature, and not everybody walks around with a thermometer to check somebody's temperature when they come in contact with them. So hot person that you know has been exposed to heat, that is not acting like themselves, or that is complaining of any of the heat exhaustion symptoms that we talked about, it's always a good idea to call an ambulance, and if nothing else, at least remove them from the heat if you can to a cooler location.
Great advice. So what kind of heat-related cases end up in your department, and then how do you treat these patients once you see them?
We see quite a spectrum, ranging from things as simple as a little bit of heat rash in people who've been working outside when it's quite warm, all the way to patients who come in who are completely obtunded or unable to speak and unable to communicate with temperatures as high as 107 or 108 degrees, who require intensive medical therapy.
So then what's that deciding factor for being treated by EMS and not needing to make that trip to the hospital? How do they know on the spot?
So really, EMS does a great job of kind of evaluating on scene if this is something that they can turn around and get the patient kind of back towards normal and into a set of circumstances where they can take care of themselves and get themselves out of the heat. So a great example of this is if they get called to the scene for an athlete that somebody is concerned is having heat exhaustion or heat stroke. We see this a lot in around this time of year in our teenage football players who are doing their practicing outside. So this is a patient who they may take into the ambulance. They will kind of remove as much of the clothing as they can and then do things to try and help the patient evaporate off some of their heat. This is what our body naturally does when we sweat, but EMS kind of helps people to do this by misting them with cool fluid or by putting a wet towel on them and then having them close to blowing air, such as a fan. This can kind of help to evaporate off some of that temperature. Additionally, if people are dehydrated because of the amount of sweating that they've been doing, EMS can provide people with some IV fluid, and that in and of itself can kind of turn these patients around, get them back to a place where they are acting like their normal selves, their heat exhaustion symptoms resolve, and they can go back home or back to a cool place and not need to be transported to the hospital. If, on the other hand, EMS can't get these things resolved on scene, or if there are concerning symptoms like the patient is altered, or they're elderly and they don't have a cool place to go to, or anything else that seems abnormal on their initial evaluation, these are patients that we will usually see transferred to the hospital.
Dr. Malik, thank you so much. Great insight and advice today.
Thank you.
Well, if you knew you had a high risk of getting cancer, how far would you go to prevent it? Priscilla Brittine faced that very scenario. Janine Kiesling talked with the 37-year-old mother of 3 who chose to have her stomach removed.
When Priscilla Brittine was just 14, her mother died of stomach cancer. Since then, she's lost cousins and other extended family members also to stomach cancer. But it wasn't until doctors referred the family to the University of Kansas Health System for genetic testing that Priscilla decided she wasn't going to wait for cancer to take her.
Hi, I'm Priscilla with Respiratory.
Priscilla Brittine is a respiratory therapist at the University of Kansas Health System.
Have you been coughing up anything?
No.
She loves her job, so when the time came to make some life-changing health decisions, she knew she was in the right hands, although getting to this point was more than 20 years in the making.
It was summer. My mom had stomach pains, took her to the emergency room. My dad did. They dismissed her, said that it was acid reflux.
Less than 7 months later, Priscilla's mom passed away from stomach cancer. It was 2001 and just the beginning of Priscilla's heartache.
I just got the call, hey, your uncle's in the hospital. You might want to come see him. He has cancer, same kind as your mom. Come say your last goodbyes. He only is given 2 weeks. And before you knew it, he was gone. And he was only 36. My cousins, they're second generational cousins. So the mom got it first. She was gone in 2 weeks. The daughter got it, I think, like 6 months after the mom did.
That's when doctors knew something was happening with this family. They sent surviving family members to the University of Kansas Cancer Center, where doctors discovered they shared a genetic mutation called CDH1, putting them at risk of stomach and breast cancers. Priscilla was tested in 2018 and learned she too has the gene.
I felt like a time-ticking bomb.
But Priscilla's doctors at the cancer center said she had options that could save her life. A gastrectomy, completely removing her stomach, and the more than 80% chance she'd get gastric cancer.
I was like, how can you live like without a stomach? Like, is that even possible?
Once doctors explained the procedure, Priscilla decided to do the surgery. She has 3 boys, 11, 13, and 17. She wants to be around for them as long as she can, and she knew she was in good hands.
Very grateful, very thankful. I actually changed my kids' doctors, and just for that reason, brought them to KU, because they will know their history, they know moms, and I'm like, this is very important. Like, this can save your life. Like, KU saved my life, like, seriously.
And here with us inside the Dolph C. Simons Jr. Family Broadcast Studio this morning is Priscilla and 2 of her doctors. Across the table here is Lauren Nye. She is an oncologist specializing in breast cancer. And Dr. Mazen Alkas-Pools is a surgical oncologist who removed Priscilla's stomach. What's it like to have Priscilla sitting in here between the 2 of you and living life the way it was intended?
It's a little weird, but you know, she comes to clinic, you know, at least now a couple times a year, I believe. So I see her quite often. We have a lot of conversations about her and her family. So
Yeah, Dr.
it's neat,
Dyke?
Yeah.
Thrilled to be here. I'm really proud of a lot of the work Priscilla has done, just spreading the message, and happy to be here with her today.
Glad you all are with us today. We want to point out right at the start that most cancers are not hereditary, but Priscilla, in your case, you and other family members shared this genetic mutation called CDH1. So how did you learn that the cancer that you had was the same as your mom, your uncle, and your cousins?
Basically, through cousins, it was word of mouth. Somebody told somebody, and I found out just by being curious, by wanting to know what my family history was.
Did you go to a genetic counselor?
I did. I ended up going to a genetic counselor, and then it's a simple blood test. Either you have it or you don't. And I had it, and the minute that test came back, changed my whole world.
Changed your world. Was it kind of a no-brainer moment for you? You
It
knew
was.
if you tested positive that you were going to take drastic measures?
I did. I wasn't going to chance this because I see my mom and her brother, and they were too young.
And then you see your three kids.
Yes.
They're young, you're young. Dr. Alcaz-Pools, Priscilla had her stomach removed. What other options would she have had?
Yeah, I mean, certainly there are other options. We don't necessarily recommend the other options, but she could have chosen just to continue surveillance, which basically would have looked like every 3 to 6 months she would have had to have endoscopy, where they look down through the mouth and the esophagus into the stomach. And then, they do biopsies, a lot of biopsies, I think something like 30 to 50 random biopsies. And, if any of them come back positive, then she goes on to undergo the surgery. Unfortunately, the type of cancer you get from CDH1 is a kind that it's not easily diagnosed through endoscopy. It can easily be missed because of where it begins in the stomach. It begins in the outer wall of the stomach. And when you're doing endoscopy, you're looking at the inside wall, the inside lining of the stomach. So you can do all these biopsies, they can come back negative, but it doesn't necessarily reassure her treating physicians, the physicians that she sees, or the patient either. So we always recommend the prophylactic gastrectomy at a certain age.
At a certain age.
Yeah.
Dr. Nye, if you have this genetic mutation, doing surveillance as another option, is it just lying in wait until you get that ultimate diagnosis? Is it inevitable? What would a patient be looking at?
An incredibly high risk of gastric cancer in individuals with the CDH1 mutation. It can be as high as an 80% lifetime risk of gastric cancer, and also a high risk of breast cancer. And similarly, a breast cancer that tends to hide within the breast and is not as easily detectable on standard mammography.
So now that the stomach is gone, what kind of surveillance is there? What's necessary, and could it still pop up, or is she in the clear?
Well, technically, if the stomach is removed the proper way, and you don't leave any of the lining of the stomach behind, then you can't get stomach cancer.
Gotcha.
But then she's at a higher risk of developing other cancers, and that's why she goes to a high risk clinic for that reason.
So we heard you talk, Priscilla, in the package. Of course, life changes when you remove a part of your body, and an important part. What has changed most about your life since having your stomach removed? Besides the peace of mind.
The way I eat, it's a whole new plumbing. I have to I retaught myself how to eat. It was very hard the very first year. I'm getting used to it. I have to eat slow, make sure I chew all my food. At first I couldn't drink and eat at the same time. I can do that here and there, but sometimes with the water, it can't be like with ice too cold for some reason. I don't know the reason behind that. I just can't drink it.
Well, I want to get back to that. I want to ask about this plumbing, so people can kind of get a visual of what's going on once she takes something in.
Yeah, so normally the stomach is used to churn food, so it breaks it down somewhat before it goes into the small intestine. But when you remove the stomach, food literally goes from the esophagus into the small intestine. So all of the digestion and absorption of the nutrients occurs in the small intestine. So you obviously can't eat large amounts. You have to eat small amounts because you don't have this reservoir. And then, so you have to eat frequent smaller meals. You can't drink a lot of fluid with each meal because otherwise you get full quickly. So you have to learn to drink between meals. And then, of course, you can't eat certain things in high volume, like sugars. Like simple sugars are bad because you can get something called dumping syndrome. And it's an awful feeling. I'm sure everyone cheats, so I'm sure that she's experienced it a couple times. But I heard it's just a terrible feeling. Yeah, go ahead. You can describe it.
You learn as you go, I would imagine,
Yes.
and check different things out and see how your body takes it.
Yes.
What's been a bad experience? Has sugar been?
Sugar.
Okay, tell us about it. I want details.
I get very sweaty, very diaphoretic. I feel like I'm going to pass out. My heart rate goes up. I get nauseated and have diarrhea, but it's all at once. Like for the first, it lasts probably just 2 or 3 minutes, but then it goes away. And after that, I'm so exhausted. Like I felt like I just ran a marathon.
So lifestyle-wise, we talk about taking something for granted. I mean, we're all foodies in some way. We enjoy going out with our friends and having people over for dinner, and we grab a bite here and there. Is just the eating experience totally different than it's ever been? It's kind of a non-factor. You just eat to live, not
Yes.
live to eat.
Yes,
Yeah.
it is. It definitely is. But I won't necessarily, I won't take sugar completely away.
Well, don't be crazy. You
You
can't.
I take a bite here
Yes.
and there. I portion.
As it probably should be in the first place. I'm sure docs would agree. Sugar's not the best for us, but yeah. So the gastrectomy was just to be safe, but it turns out that you actually found cancer in Priscilla's stomach after it was removed. Is that correct? So how do you make sure it's out of there?
How do you make sure the stomach is complete?
Yeah, so you find after it was removed.
Well, I mean, so basically you take the stomach at a point in the esophagus just before it goes into the stomach. Okay, and then you take after you remove, like you get past the stomach and you go into the very first portion of the small bowel called the duodenum. So you come across the duodenum. So you make sure absolutely that all the lining of the stomach is gone. That's how you know it's gone. Yeah.
So let's talk about breast cancer risk, Dr. Knight, and what kind of monitoring you're doing and where the connection is. We have stomach cancer, and now we're watching out for breast cancer. What does that look like?
Correct. The CDH1 mutation puts women at an increased risk of breast cancer as high as 50 to 60% in their lifetime, and we monitor them very closely with both an annual mammogram and an annual breast MRI, and typically we start that at age 30, sometimes even younger, depending on family history.
So do you talk about something like a preventative mastectomy at this point?
We do discuss risk-reducing mastectomy as an option, and that can significantly reduce the risk of breast cancer. It's really complex. In someone with a CDH1 mutation, we watch our patients go through the gastrectomy, and there's a lot of recovery involved, so I don't see it happening at incredibly young ages until they've recovered from the gastrectomy.
So for both of our doctors, just how important, though, is that genetic counseling? A lot of people wouldn't know to go get that. In this case, Priscilla, in the know, she had this experience and knew about that mutation from your family members, but a lot of people wouldn't know about that or have ever heard of that.
Yeah, what's interesting about CDH1, when I was a resident and training as a fellow, I mean, that CDH1 was around, but you never talked about it, you hardly saw patients with it. What's happened, though, is I think the criteria to get genetic testing now is less stringent than it was in the past. So we test people a lot, like even if they've had like one relative or if they had a history of lobular breast cancer. So we tend to screen people sooner, and it seems like the incidence is higher, but it's not true. We're just diagnosing it more, and so, yeah, I mean, genetic testing is everything. If you suspect it, that's the only way we'll know that somebody has a high risk.
Does that mean that everybody in the family needs to be checked? And I know that your other cousins were checked as well, and I think we have a photo of them. So how do you know, and does that mean that everybody is at that risk of that mutation? And did they all have that gastrectomy?
Yes, they did.
And what do you guys think about that? Good choice?
I think it's good. I mean, it's like doing prophylactic organ removals for a lot of things, like breast and colon, and whenever you have a genetic syndrome where the high risk is high, it's tough. Screening can be difficult for a patient, and it gives people ease of mind to remove that organ. Although I have to say, a stomach removal is a big deal. I mean, that's not a simple.
Well, out of the limited choices we have, it's our best choice.
Is it the best choice for life-saving measures, though?
Absolutely,
Right.
yeah,
I mean,
absolutely.
especially
No doubt about
when you
it.
have young kids like Priscilla. Dr. Knight, does that mean that you think her children should be tested for this at some point, and when would that be?
So when somebody in your family has a mutation, that means that their close relatives all have a 50% chance of also having that mutation. So siblings, children, parents, it came from somebody and it can be passed down. And they do frequently undergo genetic counseling at younger ages than most of our hereditary cancer syndromes, and they should do that with a genetic counselor.
And with those cousins that we just saw the picture of, was everybody on board? I'm sure not everybody was as gung-ho as you were, but did you help them get over the line?
Yes, they helped me more. They had it first. And then
And they had the removal first?
the removal first. And then I had it. I was the youngest out of the family.
You just don't see that very often, Doc.
No,
Doc, you just don't.
We don't, and I mean, certainly we prefer to have it done earlier in life. You know, in women, we like to do it before they're 30, and men, it's a little bit higher, before the age of 40. You like to do that prophylactic gastrectomy in these patients. That's what the studies have shown, at least, yeah.
So Priscilla, you now advocate for stomach cancer awareness. You actually traveled to Washington, D.C. You met with Kansas Congresswoman Sharice Davids. What was that like, and what did you come away with that trip? Is there more work to do?
There definitely is more work to do. Stomach cancer needs more awareness, more funding for research. The experience was amazing.
I bet.
Amazing. I met so many people from all over the world that either had a partial gastrectomy, meaning half of the stomach out, a total gastrectomy, also had CDH1, also had mastectomies.
You don't
and
feel like you're
all
on an
different-
island
no,
alone.
right.
That you're in the same boat, and you know that there's others working hard to make the change too.
It was amazing meeting her, and we got to share our individual story. There's 3 of us that was from the state of Kansas that represented, and it was amazing.
Very cool. Keep going back. Keep being loud. Okay, so if you have any questions, use the chat on YouTube, Facebook, or you can tweet us. Email the Medical News Network. Info's right there on your screen. Let's get a quick check on our COVID count. Dr. Dana Hawkinson, good morning on this Friday.
I know, it's nice, a little bit warm.
Always.
I heard it was the warmest month in recorded history, actually.
I believe it.
So, yeah, but right now, we'll go to the cases here at University of Kansas Health System with COVID cases. So far, 10 total, 6 active, 1 in the ICU. Our numbers have been really been staying under 10, which is good. Certainly, if we can get that down to under 5, and even I think we got to 2 active cases, but certainly low numbers. I know that I'm seeing a young person right now who is actually here because of it. So it is unfortunate. It still is out there. It still is circulating, although less so. And hopefully it will continue to be less so for as long as possible.
All right, Hawk, 'tis the season for tick bites.
Yeah.
So here we go. The CDC just released 2 new reports on what's called alpha-gal syndrome, where a tick bite can then trigger a red meat allergy. So unusual.
Yeah.
I'd never heard of this. We did a story on this a couple years ago. The CDC says as many as 450,000 Americans may have been affected by alpha-gal syndrome, but many of those cases are probably underdiagnosed because 42% of doctors and nurses in a survey said, like myself, had never heard of alpha-gal syndrome. So if someone develops a red meat allergy, it'll be hard to ignore those symptoms, but it sounds like it might be harder to connect the allergy back to the tick bite. How do you help us connect the dots?
Yeah, I mean, those ticks, they spread bacteria, viruses, parasites, and now food allergies. It seems kind of unconscionable. But what, I think we need to be careful and really just kind of lay the facts out. It certainly, there is an entity of the alpha-gal allergy, which is an allergy to red meat, that can be associated with tick bites, and this typically occurs after a series of tick bites. So just because you have a tick and maybe you see a tick on you and you pull it off, that does not mean you will get a food allergy. I think we need to be clear about that. But what we see is it sometimes can occur after a series of tick bites, maybe because your body is now reacting to something that can be seen in the tick, now also that can be seen on some red meat. So it's an alpha-gal allergy. There is testing for it. You know, the estimation, is that a little high? Maybe. But I think what we need to do is really continue to get the word out. And I've talked with our head allergist, Dr. Aguirre, about this, and she's been on the show several times as well. So she sees this also. But we just need to make sure that other practitioners are aware, and I think that's what the MMWR reports are really stating, is that a lot of the people, a lot of the physicians or treating medical teams maybe are not aware of this. And so if you do have unusual symptoms after eating meat, which can be either somewhat immediate or even occur 3 to 6 hours later, and these things can be like skin itching, it can be like gastrointestinal upset or gastrointestinal symptoms, or even sometimes asthma exacerbations, and in the most extreme cases, things like anaphylaxis, in which you can't breathe and your throat closes, a severe allergic reaction. But we need to make sure that other practitioners, other people around the United States, especially where there's high endemicity of ticks, and we know certainly in the Kansas, Missouri area, we have a lot of ticks around as well. So I think that's important to note. Also, again, it's not just if you get a tick bite, but what we see is maybe it occurs after a series of tick bites. So especially those people that are in the highest risk, those that are working outdoors on a regular basis, farms, landscaping, doing other things like that.
All right, interesting stuff. Doc Hawk, thanks so much. Any reporters with us today? Let's get to some questions from our viewers. Terry wants to know, how rare is CDH1 gene?
It's very rare. In the general population, it's probably less than 0.1%. And even if you look at families with gastric cancer, it's still uncommon to identify the CDH1 mutation.
So on that note, Kirby says, I've heard of BRCA, BRCA, and now I'm learning about CDH1. How many mutations are there?
Hundreds. There's hundreds.
Okay.
There's hundreds of genes that contribute to cancer risk, and those genes can have mutations in them. In breast cancer, there's only about 10 or so handful of genes that we know of, and in gastric cancer there's even fewer that we've identified, but we continue to learn and grow our knowledge on genetics and cancer risk.
And I think it can get very tricky because, you know, what's interesting about CDH1 is you could have no family members with stomach cancer and have a history of breast cancer, and they can have CDH1. And although it's kind of controversial, although they're probably not as high risk as someone with a family with gastric cancer, they're still at a high risk of getting stomach cancer. So it gets tricky, you know, because the important thing to know is, here's what I hear from patients a lot when they if they're diagnosed with cancer, like, I don't get it, I don't have a family history of cancer. That's the first thing you hear. And what you have to tell the patient is, well, that's common. That's the most common scenario, is you don't have a family history of cancer. You know, it just happens. And but you know, we as physicians, we have to really be good about kind of detecting when there is that family history and sending the patient to a geneticist as soon as possible.
Okay, so then in walks the concern about who needs to be getting genetic testing. So I come, let's say, to my breast cancer specialist, I have no family history, but should I still be getting genetic testing?
That is also controversial.
I love a good controversial conversation.
Yes, there's thoughts about, should everyone just have genetic testing? But we really don't have enough information about the potency of some of these genes when there isn't a family history. But if you do have a family history of cancer, the first step can always be meeting with a genetic counselor who can look at your family history and identify if you meet current criteria for genetic testing. And if not, revisiting it a few years later. Our guidelines change every year, sometimes multiple times a year, as to who qualifies for genetic testing.
Good to know. Peg wants to know, does this type of stomach cancer metastasize? Could that still be a risk for Priscilla?
The answer is, you know, the answer is yes, certainly. It's a more aggressive type of stomach cancer that patients with CDH1 get. But the interesting thing about Priscilla is, although she did have cancerous cells in her stomach, she didn't have them in a way where they can actually invade into blood vessels yet and travel elsewhere. So in a sense, that's why it's even more miraculous, because we caught it before that happened. And you know, the type of cancer, like I said, is a very aggressive cancer. So she was probably just a short period away from having very invasive cancer and metastasizing and all that other stuff.
So in the nick of time.
Yeah.
Time is of the essence.
Exactly.
Yen Liang wants to know, would KRAS or BRCA1 and 2 mutation lead to stomach cancer? Just other mutations lead to stomach cancer?
So BRCA1 and 2 right now, we don't have an association with stomach cancer, although we do have associations with pancreatic cancer, so in the same area. But again, we're learning more and more about all these different gene mutations, and they can be associated with more than one type of cancer.
Do you cringe when everyone calls it BRCA? Are we supposed to be saying BRCA?
So
I will spread the word, and I will stop
Mary
doing
Claire
it.
King, who discovered the BRCA gene, calls it BRCA.
I know,
so
it's just so hard for us non-clinical
that
people
is
to
the
remember all the
appropriate
letters.
terminology to use, but I do use BRCA frequently because that's what people know.
Okay, thank you.
The other thing is FAP, which is not, it's uncommon, but that's the one we hear about a lot, which is gives you at a high risk of getting colon cancer, also puts you at a risk of getting stomach cancer. Patients with FAP can have hundreds or thousands of polyps in the stomach, and those polyps can become cancerous. So that's another genetic syndrome that people can get stomach cancer in. Yeah.
All right, last question from Greg before we get to our takeaways today. Did Priscilla notice any change in her palate? So are there any foods that are like, ooh, or now that you're like, yes, I love these? We know sugar's kind of dicey, but what's kind of changed? And
At first, there was like, I couldn't eat certain things. Okay, this is gonna sound a little silly, but I was really desperate. I was very nauseated the first 6 months. And once they took the feeding tube out, I wanted more flavor. So I had my husband go get me some Go Chicken Go mashed potatoes.
love it.
And he told me, I remember this, he told me, be careful with the gravy. And I said, okay, so took some bites. Oh, it went down so smooth, and it was fine. I was like, oh, yay,
Why no gravy? That's the best part.
I don't remember why I said no gravy, but I would have cheated too. I would have taken the gravy.
Hard not to
for
cheat
sure.
on that stuff. Well, again, like you said, you're just finding your way, I would imagine. So let's get wrapped up. Let's get our takeaways today. Dr. Nye, let's start with you. What do you want folks to remember from this chat?
I want everyone to remember to talk about your family history, and don't be afraid to ask if you qualify for genetic testing or if you should meet with a genetic counselor to better understand what is your risk.
Dr. Alcaz, what's the takeaway?
Yeah, I've said this before, with other things. I think we're seeing a lot more cancer in young patients. So I think as a young person, you never think of cancer as a diagnosis, right? So be very aware of your body. If you notice even subtle signs, you have to think cancer now. Even in their 20s and 30s, we're seeing so much of it. So not necessarily stomach cancer, but colorectal cancer.
Yeah.
So just be aware that it's out there. You can get it and see
It's a thing.
Yeah, it is
Get
a
checked
thing.
out.
Yeah,
Get to your
absolutely.
doctor.
Yeah.
Priscilla, what do you want folks to take away from your story? And again, thank you for sharing it and being so open.
Thank you so much for having me here. Basically, learn your family history, ask questions, know your body, and educate yourself. It can save your life.
Thank you all for being with us today. We always appreciate our guests and our viewers for being with us and asking great questions. Make it a great weekend, and we'll see you back here Monday at 8. Coming up Monday on the Morning Medical Update. 2 decades of pain kept David Conway from a normal life. Then surgeons implanted a newly approved device next to his spine. I'm Jessica Lovell on the next Morning Medical Update. Pain relief at the press of a button. The science behind his spinal cord stimulator that reacts to his every move. Monday at 8.
Subscribe to our Morning Medical Update and Open Mics with Dr. Stites podcast. Now everywhere podcasts are available.